Hello, my name is Tina Griffin, and I'm a renal clinical educator with Baxter Healthcare. Today we're going to be doing a presentation on the basic principles of CRRT. So let's get started. The objectives for today's course include defining renal replacement therapy, focusing on continuous renal replacement therapy and its associated modalities, identifying the clinical indications for administering CRRT, including an overview of patient selection, identifying patient access considerations, explaining the anatomy and functioning of the hemofilter, and explaining the basic principles of the solute transport mechanisms. We will begin by discussing what is renal replacement therapy and giving you its definition, purpose, and conditions. Renal replacement therapy is actually an umbrella term that encompasses many different modalities, both intermittent and continuous. Intermittent therapies include IHD and SLED. IHD is known as intermittent hemodialysis and is actually the most commonly performed type of renal replacement therapy in both a chronic and an acute care setting. It's often employed in the ICU for patients who are more hemodynamically stable. IHD pulls off a lot of fluid and clears solutes in a very short amount of time, making it highly efficient. But the disadvantage to IHD is because of its quick fluid removal and solute removal, it's not appropriate for hemodynamically unstable patients. In many cases, they are too unstable to tolerate the fluid and electrolyte shifts that occur with intermittent hemodialysis. So in an ICU situation, IHD is often not an appropriate choice for these hemodynamically unstable patients. There is a derivative of IHD called SLED, sustained low efficiency daily dialysis, that, like IHD, use dialysate solution to target small molecules and to remove fluid. But SLED is different from IHD in that instead of being a 3 to 4 hour treatment every other day, SLED, or sustained low efficiency daily dialysis, is just that. It's performed on a daily basis. The fluid removal is accomplished at a slower rate. Fluid is administered at a slower rate. Solutes are removed slower and more gently. So for patients that are less stable, in many cases they can tolerate SLED when they can't tolerate IHD, so it's often employed in the ICU as well. Then you have continuous renal replacement therapies, the goal being 24 hours or longer, and they're almost exclusively performed in the ICU. In essence, if you have a patient that is stable enough to be on the floor or a less acute unit, then generally they are stable enough for IHD or SLED. For continuous therapies, depending on the equipment that your hospital has available, there are 4 modalities that you can offer: SCUF, CVVH, CVVHD, and CVVHDF. We will be discussing these modalities in detail later. This is a general broad definition for CRRT. It's any renal replacement therapy intended to be applied for 24 hours a day in an ICU environment. But CRRT is not simply ICU dialysis. It actually employs a variety of blood purification techniques, which may differ significantly according to the purpose that the doctor wants to accomplish. What type of solute they're trying to remove from the patient's bloodstream, the type of filter that's being used, the presence or absence of dialysate solution, as there are therapies in CRRT that do not use dialysate solution, and the type of vascular access that's being used. This slide offers us a prescription comparison summary of the 3 most commonly performed dialysis or renal replacement therapy treatments in an ICU environment: IHD, SLED, and CRRT. As far as dosing in IHD or SLED is often done with a formula called KT over V or URR, whereas in CRRT, dosing is in milliliters per kilo per hour. We'll discuss dosing more in detail later in this presentation. We've already discussed duration. IHD is generally a 3 to 6 hour treatment every other day. SLED is a 6 to 12 hour treatment every day. and 24-hour therapy is continuous for CRRT. Blood flow rates can vary between the treatments and also vary based on the modality that's being ordered, based on the equipment that's available, and physician preference. In CRRT, typical blood rates can be anywhere from 150 to 200 milliliters per minute, although higher blood flow rates and lower blood flow rates are seen based on specific patient considerations. We've talked about this briefly in that IHD and SLED only uses dialysate solution for their therapies. When you do CRRT, depending on the modality the doctor has ordered, another solution is also used. It's called replacement solution. Dialysate targets small molecules in the patient's bloodstream. Replacement solution targets larger molecules in the patient's bloodstream. So when you do these two therapies, IHD or SLED, you're removing smaller molecules, and when you do CRRT, based on the modality the doctor's ordered, you're removing those small molecules, but also larger molecules with a replacement solution. One of the most important differences between IHD and CRRT are the fluid administration rates and the fluid removal rate. It's very typical in IHD to infuse fluid 300 to 600 milliliters a minute, or even faster. It's much slower in the CRRT. Same for fluid removal. I've seen IHD treatments where they've removed up to 2 or more liters an hour off of a patient, whereas in CRRT it's typical to remove around 0 to 200 milliliters an hour, although some patients can tolerate a higher rate of fluid removal, and that depending on patient characteristics. You're accomplishing the same thing with CRRT, only you're accomplishing it over a 24-hour period, similar to a native kidney, rather than all in one short amount of time like you do with IHD or SLED. Something that is interesting that some nurses do not know when they're starting CRRT therapy is that in the world of traditional dialysis, the dialysate solution that's used is a non-sterile solution. In chronic dialysis patients, or even now in your hospital when a dialysis nurse comes to perform a treatment in the ICU, the dialysate solution that they use is non-sterile. It's not considered a drug by the FDA, it's considered a medical device. The reason it's considered so is dialysate never touches the patient's bloodstream. Blood enters the filter through hollow fibers. The dialysate is infused on the outside or bathes those hollow fibers, and the blood and dialysate never touch. Because of this, the dialysate solution does not have to be sterile and is considered a medical device. In the world of CRRT, we use sterile dialysate solutions. It still functions as dialysate should, in that it doesn't touch the bloodstream, but for safety and other reasons, only sterile dialysate is generally used in CRRT treatments. Next, we're going to discuss fluid movement, the distribution, movement, and mechanisms of fluid movement within our body. As most of you already know as nurses, the human body is made up of about 40 to 60% water or fluid in the adult population. This, of course, can vary based on gender and other characteristics. For example, an infant or neonate is closer to 70 to 80% water. All of that fluid that is in our body does not exist in one space. The body fluids exist in two major compartments, the intracellular fluid inside the cells and the extracellular fluid outside the cells. Our extracellular fluid is comprised of interstitial fluid, the fluid that surrounds our cells, and then our intravascular fluid that's in the plasma in our vascular system. For the purposes of renal replacement therapy, we are primarily interested in the fluid that's in our intravascular space because that's where fluid has to be for us to remove it when we're fluid overloaded or we have electrolyte or acid-base imbalances. We can't realistically remove fluid from the intracellular interstitial space, so we have to get that fluid to move across these membranes or these capillary walls into our intravascular compartment. Fluids and solutes are constantly shifting between these compartments, interstitial, intravascular, intracellular, to transport nutrients, waste, and other materials. And as we discussed, they pass through these walls across capillary walls that are semi-permeable. Water passes very freely because it's low molecular weight per se, and some solutes do as well. But other solutes don't pass as freely back and forth across these compartments. Based on properties of the molecule, it takes different levels of energy or different transport mechanisms to move things back and forth across the capillary walls. So our body actually uses two major transport mechanisms to move things across these walls, both passive and active transport. Passive transport is movement of solutes from an area of high concentration to low concentration. It requires absolutely no energy to move by passive transport. Another term for passive transport is diffusion, simple or facilitated diffusion. This is actually what hemodialysis is. Hemodialysis is simple or facilitated diffusion or passive transport, moving solutes from an area of high concentration to an area of low concentration. An example of a molecule that moves by passive transport is sodium. Sodium is one of the lightest weighted electrolytes in our body. It weighs 23 Daltons. So sodium is very easily going to diffuse back and forth across capillary walls or these membranes. This may explain why it is sometimes so common for a patient to get hypernatremic or hyponatremic when you're having major fluid shifts because of the low molecular weight and the ease of diffusion with sodium. But then you have just the opposite of passive transport. You have active transport. That's moving solutes from an area of low concentration to an area of high concentration, and this requires energy. There will be some property of that molecule that requires energy to move it across the membrane. So in CRRT, based on the electrolyte composition that's in the bag of fluid, based on the modality that the doctor has ordered for your patient, it's going to create either active or passive transport on the machine and mimic how those mechanisms work in the native kidney. So why CRRT? Who are your CRRT candidates? What makes a patient appropriate for CRRT as opposed to another type of renal replacement therapy? CRRT is indicated in any patient who meets the criteria for hemodialysis but can't tolerate intermittent dialysis due to their hemodynamic instability. So patients with the following diagnoses may be candidates for CRRT when they're hemodynamically unstable and in an ICU environment. Fluid overload. Fluid overload is an independent predictor of mortality, independent of any other comorbidity. And the more fluid overloaded a patient is, the greater their risk of mortality. Renal replacement therapies have been shown to be effective in managing fluid overload in patients that are hemodynamically unstable. Acute renal failure, like chronic renal failure, is an indication that your patients no longer have kidney function, and a supportive therapy, like renal replacement therapy, may be appropriate in treating acute renal failure. If your patient has a life-threatening electrolyte imbalance, say a potassium of 7 or a bicarb of 12, and they have not responded to conventional or traditional measures, renal replacement therapy may be an appropriate alternative for treating these electrolyte imbalances. We discussed briefly replacement solution and how it is an addition to CRRT therapy and that it targets larger molecules in the patient's bloodstream. So patients with conditions like burns or drug overdoses or other conditions where they're producing larger inflammatory cytokines, in some cases CRRT therapy may be more appropriate for these patient considerations than intermittent hemodialysis or SLED. But if you compare IHD and SLED with CRRT, CRRT allows for graduate solute removal that approaches the homeostasis of normal kidney function. In other words, CRRT closely mimics our own native kidney in treating acute kidney injury and fluid overload. In 2012, a set of guidelines were published to help guide clinicians in the management of acute kidney injury. These are called the KDIGO guidelines, Kidney Disease Improving Global Outcomes. This clinical practice guideline presents a set of information, opinions, and suggestions by the KDIGO work group. This is an international collection of AKI experts. It's designed to provide information about acute kidney injury and its management, but it is not intended to define a standard of care or to prescribe an exclusive course of treatment. Every healthcare professional making use of these suggestions and opinions is responsible for evaluating the appropriateness of applying them in the setting of any particular clinical situation. A level 1 is defined as most patients should receive this recommended course of action. A level 2 is defined as different choices will be appropriate for different patients. A not graded is defined as used typically to provide guidance based on common sense or where the topic itself does not allow for the application of evidence. As far as the quality of evidence to support it, a grade A is defined as high quality evidence, B is moderate quality evidence, C is low quality evidence, and D is defined as very low quality evidence. Prior to the publication of the KDIGO guidelines, there was no definable criteria for the diagnosis of acute kidney injury. The first international interdisciplinary consensus criteria for the diagnosis of AKI was the rifle criteria that was proposed by the Acute Dialysis Quality Initiative Group, or ADQI, with the publication of the KDIGO guidelines. RIFLE stands for risk, injury, failure, loss, and end-stage renal disease. The RIFLE criteria has been validated as an accurate predictor of mortality in greater than 500,000 patients. The later the stage, the risk, injury, failure, a patient is diagnosed, the higher the predicted mortality rate. The 3 severity grades are defined on the basis of the changes in serum creatinine or urinary output, where the worst of each criterion is used. For example, stage 1, or the risk stage, is defined as having either a urinary output of greater or less than 0.5 mils per kilo per hour for 6 hours or more, or an increase in your serum creatinine of greater than 50%, a GFR that's decreased by more than 25%. Another definition that's not listed on the slide of a stage 1 of acute kidney injury is defined as having an increase in your serum creatinine of more than 0.3 milligrams per deciliter if it's occurred within the last 48 hours. So that's stage 1, or the risk stage. And then, as we discussed, the further you progress between risk, injury, and failure, the greater your risk of mortality. The 2 outcome criteria, loss and ESRD, are defined by the duration of the loss of kidney function. This concept of acute kidney injury as defined by RIFLE does create a new paradigm, because acute kidney injury is not just acute tubular necrosis, or is it just renal failure. Instead, it encompasses both, but also includes other less severe conditions. You'll note on the slide that it notes sensitivity or high specificity. The definition of these are: sensitivity is the fraction of people with the disease that this test correctly identified as positive, and specificity is the fraction of people without the disease that the test correctly identifies as negative. As we have discussed, fluid overload is independently associated with mortality in acute kidney injury patients. In 2010, there was a study performed called the CRRT study that compared CRRT and IHD for correction of fluid overload, and it was suggested by the CRRT study that CRRT may be better than IHD for fluid removal. Some reasoning behind this is that with IHD and SLED, you have to remove the accumulated fluid in a short period of time. This often requires the patient to be weighed in order to calculate the fluid removal, and this can be inaccurate and complex in an ICU population. Also, larger volumes are removed with IHD and SLED. This increased risk of excessive fluid removal can lead to hypovolemia and hypotension and can slow renal recovery. With CRRT, you have regular recording and adjustment of fluid losses and gains, and this allows for precise management of patient fluid balance. CRRT also allows for the progress to be made at the appropriate speed and direction to achieve the prescribed goal for the patient. The following is a list of potential conditions that may lead to acute kidney injury in the ICU population. Patients with acute kidney injury and at increased risk for acute kidney injury require careful attention to their hemodynamic status. This is because hypotension results in decreased renal perfusion, and if severe or sustained, may result in kidney injury. Management of blood pressure and cardiac output require careful titration of fluids and vasoactive medications. Patients with AKI are also at an increased risk for fluid overload, colloid versus crystalloid fluids, and continued fluid resuscitation, despite increased intravascular volume, can cause harm. So fluids and vasoactive medication should be managed carefully and in concert with hemodynamic monitoring. So some potential conditions that may lead to acute kidney injury because of changes in renal perfusion are organ failure, such as liver, cardiac, renal, or multisystem, sepsis, burns, drug overdoses, or organ transplants. This particular case study, we're going to look at this case study, just look at the clipboard, and based on the numbers that we see, determine whether or not this patient has abnormal kidney function. So you have an 82-kilo female who's been in the ICU for 3 days with a diagnosis of pneumonia and sepsis. She's previously fit and has no comorbidities that would preclude her to having any sort of kidney disease that you know of. Her labs this morning, a creatinine is 1.1, a normal creatinine. The BUN, the K, the white blood cell count, they're elevated, obviously. In the last 48 hours, the patient's had almost 12 liters in, a little over a liter out of urine. The patient is on a ventilator, on 2 pressors with a MAP of 59, and with Lasix is putting out 0.4 mils per kilo per hour. So according to this case study, does this patient have abnormal kidney function? Well, the creatinine is within normal limits, but there are other indicators of trouble, such as that elevated white count and a MAP of 59, even on pressors. If you look at the rifle criteria again, and the criteria for hemodynamic stability and urine output, then you can see that this patient is fluid overloaded, almost 12.4% fluid overloaded, which significantly increases their risk of mortality. So yes, this patient does have abnormal kidney function. Next, we're going to discuss access and review vascular access for CRRT. The KDIGO guidelines give specific recommendations for vascular access. The desired characteristics are a French size of at least 11 French for adult patients. The actual range given in the guidelines is 11 to 14 French. But just as important as the French size of the catheter is the length of the catheter and the placement. Access issues are the #1 circuit management issue in CRRT. Almost 40% of interruptions in CRRT therapy are related to a patient's catheter or to their access. All hospitals have their own specific protocols and policies for guidelines for central line dressing changes or access. So make sure that you always refer to your hospital's specific policies and protocols when addressing any access issues. The KDIGO guidelines give specific preferences for catheter insertion, placement, and length. The first recommended or the first choice from the guidelines is the right internal jugular or right IJ vein with a recommended catheter length of at least 12 to 15 centimeters. Many programs have found that the longer length catheter tends to be more efficient or is associated with better outcomes than the shorter length, but 12 to 15 centimeters is the recommended length choice for the right IJ. One difficulty with the right IJ is that many times when CRRT has been ordered, the right IJ is not available because another catheter is already in its place. So as a second choice, if the right IJ is not available, the KDIGO guidelines recommend the femoral vein with a recommended catheter length of 19 to 24 centimeters. This is often an issue with many implementations that are done for CRRT because many facilities do not carry 24 centimeter or longer catheters in their stock, and they have 19 centimeters or less. Although the 19 centimeter catheter is appropriate for many femoral patients, patients with long torsos or extremely tall patients may definitely need the longer length femoral vein to be effective for therapy. As a third choice, if the right IJ or femoral is not available, the left IJ with a recommended catheter length of 15 to 20. Since it has to go across and down into the heart, it is recommended that it's a little bit longer. So first choice, right IJ, 12 to 15 centimeters. Second choice, femoral, 19 to 24 centimeters. And third choice, left IJ, 15 to 20. As a last choice, if the first three are not available, the subclavian vein with a preference for the dominant side. It's not recommended by the KDIGO guidelines to use a subclavian vein because of its association with both pneumothorax and hemothorax, but also central venous stenosis. If a significant central venous stenosis occurs in a subclavian vein, it makes it unusable for an AV fistula or an AV graft. Many acute kidney injury patients need permanent or temporary dialysis following their acute kidney injury event. So the ability to be able to have an AV fistula or an AV graft for therapy is important. So the KDIGO guidelines do recommend avoiding a subclavian vein if at all possible if there's another access available. Just like any other central line that you work with in an ICU environment, the hemodialysis catheter, or VAS cath, can present complications. Some of these may be mechanical, such as kinking, malposition, patient positioning or leakage, or thrombotic complications such as thrombosis, fibrin sheath, or clot formation. In general, the care of a central line is the same regardless of whether it's a VAS cath or a central line, especially when it comes to dressing changes. One caveat or exception to this is when you are aspirating a hemodialysis catheter or a VAS cath for patency. In many cases with central lines, the general rule of thumb is to flush the catheter and then aspirate for patency. This is not recommended with a VAS cath or hemodialysis catheter because they are often packed or locked with an anticoagulant such as heparin or citrate to maintain the patency of that catheter. If you were to flush a hemodialysis catheter before assessing it for patency or before aspirating, then you would inadvertently, in many cases, give your patient a bolus of heparin or citrate or whatever that catheter happens to be packed with. So a good general rule of thumb for all hemodialysis catheters or VAS caths is anytime you access it, whether it's to assess it for patency, to draw a lab, to connect it to a circuit, you should always aspirate it to remove any anticoagulant that it might be packed with, and then assess it for patency or use it for whatever intervention you are intending to use it for. One potential complication that can occur with CRRT therapy are CLABSIs, central line associated bloodstream infections. As most of you know, a CLABSI is a primary bloodstream infection that develops in a patient with a central line when it's not related to infection at another site. CLABSIs, of course, affect your hospital's reimbursement and other factors, and so hospitals are very stringent in making sure that nurses follow the proper procedures in caring for patients' central lines. So it's just important to remember that you will be accessing your patient's central line frequently during CRRT therapy, and every single time that line is accessed, it presents a risk for CLABSI. So make sure that you're following very carefully your hospital's policies and protocols for central line dressing changes, accessing catheters, the protective equipment, the PPE that you wear during a central line dressing change or accessing a catheter, your proper procedures for disinfecting, aseptic technique. But it's also very important to remember your patient at this time as well. Your patient needs to be protected in the form of a mask if they're not vented. There have been many times where during a dressing change or during a filter change that the nurse is very well protected with PPE, but the patient is not vented and does not have a mask and is a source for a potential CLABSI. So just always remember to protect yourself, but also to protect your patient with a mask if they are not intubated. Next, we're going to discuss the hemofilter. The hemofilter is a blood filtering device used mainly to support the excretory functions of the kidney. In other words, it helps to mimic your native kidney and basically takes the place of your native kidney during an acute kidney injury event. Generally, if you look at a diagram, the blood is going to enter through the bottom of the filter and then enter through thousands of hollow fibers, or basically hollow straws that are semi-permeable. So the hollow fibers in a dialysis filter or dialyzer are like straws that have several little semi-permeable holes in them. So certain solutes can pass across that membrane and certain solutes can't. So in this cross section you would see that blood would be going through the center of that hollow fiber. The dialysate would be infused on the outside of that hollow fiber, and the dialysate and the blood never touch. And certain solutes will be able to move across the pores of this semi-permeable membrane. It functions very much the way that our native kidney functions, and that we have the renal artery that brings in blood into your nephron, which is your glomerulus and your tubules, and then the renal vein that takes the cleaned blood back out into your patient. The urine or the waste that is produced in this process will go into the collecting duct and out into our body. So the artery brings the blood into your glomerulus, which does glomerular filtration and filters out larger molecules in your patient's bloodstream. The proximal and distal tubules work to balance out electrolytes and acid-base balance and tubular reabsorption and help to kind of balance the smaller substances in your patient's bloodstream. And then when that process is complete, the efferent arteriole will then take the cleaned blood back out into the body. Waste obviously has been created in that process, your urine, which will come out into the collecting duct, out into your patient's body. Out into the urine. The way that our machine basically mimics this process is rather than have the arteriole that brings the blood into the kidney, we have the blood pump that brings it into the filter. The filter then acts like the glomerulus and the tubules and does the same functions. And then the blood pump acts like the efferent arteriole, or the renal vein per se, and pumps the blood back out into the body. Our effluent pump will then take the urine that's been created, the waste, the effluent, and remove that out into the waste bag that's in the machine. Video that will also explain the function of the kidneys, and we'll illustrate this for you. So in your bloodstream, you're going to have substances like electrolytes, waste products, and other things like cytokines and mediators that one of the functions of our kidney is to filter out and clear. So when the kidney's working like it's supposed to, that blood is coming into our nephron, and we have the glomerulus working and the proximal and distal tubules working, and we have normal waste removal, and very little waste goes back into the patient's bloodstream. And that's what we want to happen when our kidney is working normally. In an acutely injured kidney, that same process is attempting to occur. Blood goes in, blood goes out. But since the process is impaired right here, we have very little waste removal, and all that waste is going back into the patient's bloodstream. We don't want that to happen, so we put a patient on CRRT or a renal replacement therapy, and now the filter is mimicking the functions of your native kidney. And the effluent pump is taking that waste that's created out into the waste bag. So during a time that a patient's on a renal replacement therapy, basically the renal replacement therapy is mimicking the function of the native kidney. Next, we're going to discuss the basic principles of solute transport and how different transport mechanisms work to remove fluid and solutes from our patient's bloodstream. There are basically 4 transport mechanisms. There's ultrafiltration, which is the primary transport mechanism, and that's what transports fluid or in this case, urine out of your body. The way that we get rid of waste from our kidneys is through our urinary output. Solutes are transported through three different mechanisms: diffusion, convection, and adsorption, which we will also discuss. But all of those solutes are going to be in the fluid that is removed through ultrafiltration. Ultrafiltration is simply the movement of fluid through a semi-permeable membrane, and it's driven by hydrostatic pressure. In a nutshell, if you drink 2 gallons of water a day, you're going to produce more pressure in your kidney than if you drink 6 ounces of water a day, and you'll produce more urine if your kidneys are functioning normally. The way that our machine mimics that is we have an effluent pump, and the effluent pump forces the plasma water and the solutes across the semi-permeable membrane in the filter. So if you set the effluent pump, or you set the patient fluid removal for 1,000 cc's an hour, that effluent pump is going to create more pressure than if you set the pump for 100 cc's an hour, and it's going to remove more fluid from your patient. So it's based on the pressure that you're creating. The next transport mechanism we will discuss is adsorption. Adsorption is molecular adherence to the surface or interior of the membrane. In the diagram on the right, very little solute is actually passed through the membrane. It's adhering to the membrane. Think of an air filter, like the one in your furnace. As the air passes through it, impurities cling to the filter itself. Eventually, the impurities will clog the filter and it will need to be changed. The same is true in blood purification. High levels of adsorption can cause filters to clog and become ineffective. However, not all filters or all membranes possess this adsorptive quality. To predict whether adsorption will play a role in the clearance of a specific substance, it's necessary to identify the specific properties of the membrane and the targeted molecules, although we will not go into this today. Diffusion is the next transport mechanism. Diffusion is also known as hemodialysis. It's the movement of solutes from an area of high concentration to an area of low concentration. We discussed this earlier when we discussed passive and active transport. So basically, the way diffusion works. Look at this slide. The bottom represents your patient's bloodstream. The top represents the dialysate solution the doctor's ordered. So let's say, for example, that your patient has a blood potassium of 6.8. You want to get that potassium down, of course, before your patient starts to have adverse effects, so your doctor orders a bag of dialysate with 4 milliequivalents of potassium per liter. You have just created a concentration gradient. The lower concentration of potassium in the bag of dialysate is going to cause the excess potassium to diffuse out of your patient's bloodstream until it equilibrates on both sides. It happens in both directions. Say your patient's acidotic and they have a bicarb of 18. You hang a bag of dialysate with a bicarb of 32, and now the bicarb is going to diffuse out of the dialysate into the patient's bloodstream until it equals. If your patient's sodium is 140 and the bag of dialysate is 140, well then nothing's going to move because it's already equal on both sides. Blood always goes in one direction, and the dialysate goes in the other direction to create a countercurrent flow. There are many factors that affect diffusion. The concentration gradient is one of the primary ones. The stronger the concentration gradient that you create, the more solutes or the quicker the solutes you're going to clear. For example, for that patient on the previous slide that had a potassium of 6.8, if you hang a 0K potassium, you're going to clear solutes much more quickly than if you hang a 4K potassium because you're creating a much stronger or steeper concentration gradient. However, anytime you hang any solution that's non-normal physiologic, a 0K bag or a 2K bag, be sure to monitor your patient's labs on a frequent basis according to your hospital's policy and protocol. Because let me give you an example. Let's say that you have a patient with a potassium of 6.8 and your doctor wants to get that potassium down a little bit quicker. They may order a 0K or a 2K bath per se for that patient. If I hang a 0K against a patient with a potassium of 6.8, then I'm creating a very steep concentration gradient, and it's going to pull that potassium down pretty quickly. But once I get my next renal panel, I'm checking my patient's labs, and I note that their potassium is, for example, 4. I need to notify my physician so that I can get an order for him or her to change the bag of dialysate to a 4K bag. Because if I leave a 0K or a 2K bag hanging, then it will continue to diffuse the potassium out of my patient's bloodstream until it equalizes, and I can make my patient hypokalemic. So it's important when you're using anything other than a normal physiologic bag, or in this case a 4K bag, that you are monitoring your patient's electrolyte levels according to your hospital policy and making sure that you do not create too steep of a concentration gradient that you cause electrolyte imbalances that are unintended. One thing that's very important to remember about diffusion is that it only clears small molecules. As we discussed, sodium has a molecular weight of 23 daltons. BUN, creatinine, other waste products in our bloodstream also have fairly low molecular weights. Diffusion can clear molecular weights of up to about 1,500 daltons. Any substance or solute that's larger than that is not going to be effectively cleared by diffusive therapies, by intermittent hemodialysis or SLED therapy, or any therapy that only uses dialysate solution, because dialysate or diffusion can only clear small molecules of up to about 1,500 daltons. So when we discuss doing a or transport mechanism that can target larger molecules in the patient's bloodstream, larger than about 1,500 daltons, then we talk about convection. Convection is known as hemofiltration. Note that in the previous slide, diffusion was hemodialysis, convection is hemofiltration. Another term for this is solvent drag, because you are basically dragging those larger molecules across the filter, across the membrane. In convection, replacement solution is used to drive convection and drive hemofiltration. Remember that in hemodialysis or diffusion, dialysate is the fluid that's used to drive that particular transport mechanism, but replacement solution is used to drive convection. Replacement solution is different from dialysate, and that is infused directly into the bloodstream. So the replacement pump pushes fluid into the blood flow path, either pre or post filter that we'll discuss later, and then the effluent pump at the same time is pulling the fluid with those solutes from the blood side of the filter across that semi-permeable membrane, in essence dragging those molecules across the filter. The main things that affect convection are molecular size. If you have a patient who is producing cytokines or inflammatory mediators or molecules in their bloodstream that are, for example, 15, 20, 30,000 daltons, then you're not going to convect as much as if the only thing you're targeting in the patient's bloodstream is a molecule that's 35 or 40 or 50 daltons, which many electrolytes are. So molecular size plays a big role in what affects convection. How permeable your membrane is. A brand new filter has all of its semi-permeable pores or holes basically open and clear, and substances are going to convect more easily across that filter. But as the membrane becomes less permeable, as it clogs and there's less space for material to be able to move across the membrane, then you lose some of your convective ability. This slide demonstrates as molecules get larger, it's a little bit harder and takes more effort per se to move them across the filter until eventually you get to molecules that are too large to make it across the pore size of the membrane. So substances like urea, creatinine, glucose, electrolytes, they are relatively small and they're going to passively diffuse through the membrane. And then as these substances get larger, vitamins, minerals, microglobulins, you can see that it takes a little bit more effort to get them through the filter, and they're not going to as passively diffuse. It's going to take that convective therapy, that force of therapy to get them through there. In the ICU environment, obviously one of the most common diagnoses are patients that are septic or have inflammatory disorders, things like pneumonia, infected surgical wounds, influenza, for example. These patients are producing cytokines or inflammatory mediators that can be very heavy, that are not going to be able to be removed by diffusive therapy. Remember from a previous slide, we talked about dialysate and diffusion, and that diffusion only clears these small molecules. So when you're doing intermittent hemodialysis or you're using just dialysate solution, you're going to be targeting molecules of this size. Depending on the modality or the therapy that the doctor orders, that we're going to be discussing very briefly, you'll be using convective therapy as well, using replacement solution, which will be able to target these larger molecules that can't be removed with a dialysate or diffusion alone. So diffusion is going to clear molecules of this size, about 1,500 or less. Convection will be able to clear the larger molecules up to 50,000 Daltons. Your Dalton cutoff is 50,000 Daltons. No substance, no solute, no molecule bigger than 50,000 Daltons will be able to pass across the membrane. So your patient's not going to lose albumin or other proteins. Albumin has a molecular weight of 66,000 Daltons. So your patient will not lose albumin or other proteins of that size or larger. They also won't lose immunoglobulins like IgG or IgM, those type of things. So depending on the modality that your doctor orders for the machine, you'll be targeting either the small molecules or you'll be targeting small and large molecules. Since replacement solution drives convection, the replacement solution is administered into the bloodstream. This is different from the dialysate that we discussed. As we discussed earlier, dialysate never touches your patient's bloodstream. Dialysate is always infused on the outside or bathes the blood fibers. Replacement solution, on the other hand, is administered directly into the bloodstream. And it goes into the bloodstream either before the blood reaches the filter or after the blood has exited the filter. The benefit of pre-filter replacement is that the fluid going into the patient's bloodstream dilutes the blood, helps to decrease the hematocrit, and helps to increase that convective force. So by the time that the blood reaches the filter fiber, the hematocrit is diluted and the blood is diluted, and in some cases it can potentially help to minimize clotting issues with your patient. So that's one of the benefits of pre-filter replacement. The benefit of post-filter replacement is that it helps to concentrate the blood that's in the filter, thereby concentrating the solutes that are going to be pulled off, and can help increase clearance for your patient of their solutes, but also you will have the exact electrolyte composition that you know, so that you can deliver replacement solution to replace the removed volume and to replenish those lost electrolytes. Not every machine for CRRT is capable of doing both pre and post. Some machines are only capable of doing pre-filter. Some can do pre and post, but you have to choose which one. And then some machines can do pre and post at the same time. So you're going to have pre-filter replacement and post-filter replacement as options for therapy. Depending on the machine that you have available, there are 4 modalities that you can offer when you're doing CRRT. First, we'll discuss SCUF, slow continuous ultrafiltration. The primary goal of SCUF is to remove patient fluid. If your physician orders SCUF, there will be no dialysate solution or replacement solution ordered, so there will be no diffusion or convection, only removing patient fluid. Then you have CVVHD, continuous veno-venous hemodialysis. CVVHD is basically doing IHD or doing SLED, but doing it continuously for 24 hours because the only solution that's used is dialysate solution, and the primary goal is small molecule clearance and to remove patient fluid. So note that when CVVHD is ordered, There's no convective therapy. There's no removal of the larger cytokines. The goal is to achieve small molecule clearance and to remove patient fluid. The opposite of CVVHD basically is CVVH. CVVH is continuous hemofiltration. This is continuous convection per se. The only fluid that will be administered on the machine would be replacement solution, no dialysate solution, and the primary goal is to achieve large molecule clearance and to remove patient fluid. You're also going to achieve small and medium one clearance because those molecules are smaller. If I'm targeting something that weighs 30,000 Daltons, say a septic inflammatory cytokine, or myoglobin that weighs almost 17,000 Daltons, then just through the process of convection, the small and medium ones will also be lost because of that convective force. So 35 Dalton potassium molecules or 39 Dalton calcium molecules, 23 Dalton sodium molecules, all of those smaller molecules will also be convected and removed with the replacement solution. And so when you do CVVH, even though your primary goal is to get to the large molecule clearance, you'll also be removing small and medium ones as well. And then finally you have CVVHDF, continuous veno-venous hemodiafiltration. CVVHDF is what some people consider to be the most close to native kidney function because you're doing both the filtration portion, the glomerular portion of our kidney function, with your replacement solution and driving convection and targeting the larger molecules. But at the same time, dialysate solution is also administered, so you're getting the diffusive concentration gradient benefits, the same things that the proximal and distal tubules do in our kidney to help balance out and do tubular reabsorption. So basically CVVHDF is what some consider to be the closest to native kidney function because you're doing both dialysis or diffusion and hemofiltration or convection. You're using both replacement solution and dialysate at the same time. So the role of solutions in CRRT, the dialysate and replacement solutions are used to facilitate the removal of solutes using those basic principles of molecular transport. So just to review that in slide format, when you're doing scuff therapy, there's no fluid administered on the machine. You're just pulling patient fluid off. So you're solely just pulling fluid off of a patient. CVVH, there would be no dialysate because the doctor's not looking to do diffusive therapy. He's looking to do convective therapy, so replacement solution would be administered, and you would be removing fluid and solutes off of the patient. CVVHD is basically the opposite of CVVH, where you only use dialysate solution, do the diffusive therapy, but there's no convective therapy, there's no larger molecule clearance because you have no replacement solution, so you're pulling off fluid and some solutes because remember you're targeting the smaller solutes when you do just CVVHD, so you're not going to get all solutes. And then with CVVHDF, you have dialysate and replacement solution working together, and you're going to be removing fluid and solutes of all molecular sizes that are within the filter's capacity to remove. So we're going to revisit the case study from earlier. Basically, it's just later in the day. It's now 12 instead of 6 a.m. and we're getting her next renal panel on her. And so we need to determine what type of therapy she needs based on the results that we are looking at now. So here it is, 6 hours later, and we get another renal panel. Her creatinine has bumped up a little bit to 1.3, not very much of a bump. BUN and potassium and white blood cell count are all elevating, getting worse. She's actually a little bit more fluid overloaded. They've added an additional pressor to her and she's still on the vent. And even with additional Lasix, she's putting out less urine. So what therapy does this patient need? Well, according to the KDIGO guidelines, she's definitely hemodynamically unstable based on this. She's fluid overloaded, which is an indication, and her urinary output is also within the range to determine that she's unstable, and so probably too unstable, obviously, for an intermittent therapy. So a continuous renal replacement therapy is appropriate and what this patient needs at this point. Next, we're going to discuss CRRT dosing. Dosing in CRRT is just like dosing in any other medical condition, so it's important to dose your patient appropriately so that you can see the results that you are anticipating or want to achieve with your CRRT patient. The KDIGO guidelines that we discussed earlier give specific recommendations for dosing a CRRT patient. The guidelines suggest delivering an effluent volume of 20 to 25 mils per kilo per hour for CRRT in acute kidney injury. And this is a level 1A indication, which means it's highly recommended and there is strong quality evidence to support it. The effluent volume or effluent dose, these can be considered interchangeable terms, is actually the fluid that's being programmed into the CRRT machine that is in turn being removed or pulled into the waste or effluent bag. So basically your effluent dose consists of your dialysate, replacement, and any net fluid the doctor's ordered for the patient. Things like tube feedings, TPN, pressors, all the extra additional fluid that he or she wants to pull off the patient. And so the suggestion is to deliver an effluent volume of 20 to 25 mils per kilo per hour. You will see under that it says this will usually require a higher prescription of effluent volume. So what is meant by that is the recommendation from the guidelines is to deliver 20 to 25 mils per kilo per hour. In order to deliver something in CRRT, the machine has to be running without interruptions. Unfortunately, that's not going to be the case with CRRT. There will be interruptions in therapy. The most common interruption in therapy will be filter changes, bag changes, and access alarms. So every single time you have to change the filter because of a filter clotting or a filter clogging or just the end of the filter life, routine filter life, that's going to be downtime where there's no therapy being delivered to your patient. When bags are full or empty, that's downtime for the patient. If a patient has to come off of therapy to go to CAT scan or cath lab or OR, that's time off of therapy for the patient, that's downtime. So in reality, the machine does not run or deliver therapy for 24 hours. So by prescribing a higher prescription of effluent volume, it helps to maintain that delivered dose that the doctor's looking for. So it's recommended to prescribe higher than that 20 to 25 to account for downtime and therapy interruptions. So here's an example. Let's just say that you have a patient that weighs 70 kilos. If your doctor were to order 1,000 cc's an hour of dialysate, 1,000 of replacement solution, dialysate to do the diffusive therapy, the do diffusion, and the replacement solution to do the convective therapy, the solvent drag or the hemofiltration, and then you were pulling off, say, an additional 200 cc's an hour of net fluid, that's 2,200 cc's an hour. When you divide that by 70, by the patient's weight, it gives you a prescribed dose of 31.4, which is a little higher than the recommended of 20 to 25, and this will help to account for that downtime that your patient will probably experience on CRRT, and this patient is being dosed appropriately. So just to review that, the best evidence to date supports that dosing a minimum of 20 to 25 mils per kilo per hour in all modalities is recommended for CRRT, that it's usually necessary to increase the prescription to ensure that the prescribed dose is delivered, and frequent assessment of the actual delivered dose is recommended. There are ways on your renal replacement therapy machines, your CRRT machines, to determine what the actual delivered dose was as opposed to the prescribed dose. And then finally, when your doctor is determining the prescription of renal replacement therapy, they're going to consider other things other than just the small solute clearance. They're also going to consider your patient's fluid balance and how well they can tolerate and how much fluid they need to have pulled off, their acid base and electrolyte balance as well, and their nutrition. All of these elements work together when your doctor's writing a particular prescription for your patient. And finally, we'll talk about anticoagulation and do a clinical overview of anticoagulation strategies in CRRT. So what's the impact of filter clotting if you have a filter that clots when your patient's on CRRT? Well, obviously, lost time on therapy is one, because when your filter clots, your patient's not getting any therapy, and you have the time for filter changes that's going to impact that. If you have less clotting, it means fewer filter changes, and this may in turn reduce how many filters that you have to use and the labor intensity for the nurse. So those are some things that you can consider. Also, with clotting, if you're not always able to get the blood returned to the patient before the clotting alarm occurs, there could also be the potential for blood loss for your patient as well. So there are some negative consequences to your filter clotting. So as far as the KDIGO guidelines, the KDIGO guidelines state that in a patient with acute kidney injury who requires renal replacement therapy, the decision of whether or not to use anticoagulation should be based on the patient's potential risk and benefits. Is it more beneficial for the patient to have anticoagulation so that it minimizes interruptions to therapy, or is the patient condition one that it would be too much of a risk for them to be on anticoagulation? So you always need to weigh the benefits versus the risk for your patients. But it is recommended to use anticoagulation during renal replacement therapy if a patient does not have an increased bleeding risk or impaired coagulation, and if they're not already receiving systemic anticoagulation. So anticoagulation is important, and if the patient has no contraindication to it and they're not already receiving systemic anticoagulation elsewhere, the guidelines do recommend that your patient receive anticoagulation. Heparin is considered a systemic anticoagulant, and that regardless of whether they have a systemic heparin drip because they're receiving it for DVT prophylaxis or some other sort of medical condition, or whether the heparin is administered solely to the machine to anticoagulate the filter, there will be some systemic effects to your patient. So it can be contraindicated in certain patients, patients with GI bleeds or intracranial bleeding, those type of things. It is a high-risk medication, so it's generally monitored and assessed by Joint Commission, and in many hospitals they have protocols on how heparin is administered. And obviously, if your patient has heparin-induced thrombocytopenia or a known allergy to heparin, then that would be a contraindication. Other means of anticoagulation can be pre-filter dilution of your fluids, diluting fluids before they go into the filter. That can be accomplished with pre-filter replacement solution, and then also other forms of anticoagulation other than heparin, and that would all be based on your hospital's policy and protocol on how the physician plans to anticoagulate during CRRT therapy. But basically, it's just note to remember that the KDIGO guidelines do recommend anticoagulation in CRRT for patients who have no contraindication and who aren't already on a systemic anticoagulant. So that concludes our presentation on the basic principles of CRRT. If you have any questions, you can call our ICON number, that is 1-888-404-4266. That's our 24-hour clinical support line that can help answer questions. And also, there are other educational opportunities and videos on our website at renalacute.com, www.renalacute.com. Thank you and have a wonderful day.